everyone. Are you ready to talk more about ICD-10? I'm sure you are because it's fascinating. So we've already gone over a few things about ICD-10 and the guidelines, but now we're going to talk about some of the basics about using ICD-10, kind of reiterate and some new things that you may have already seen in the other chapters. Let's go ahead and get started. The official guidelines, you're going to hear them talked about a lot. The guidelines is really what you're tested on when you go to sit for the CPC exam or the CCS exam, any of the exams really. They know you know how to code because picking up a code is like picking out a phone number out of a telephone book, if anybody even uses telephone books anymore, right? Um, Not hard once you know what you need to look up. The guidelines, though, are the rules and the regulations that follow how to use the codes themselves. What determines which code is listed first? What do you do when you have codes that need to be for left and right? Or how do you apply modifiers? And modifiers, which we'll talk about later, can increase payment or decrease payment. Modifiers, unlike ICD and CPT codes, they aren't used for statistical purposes, really. They're just explaining, they're like the highlights of a painting that makes something pop out and give you more information about what's going on. Because remember, with the codes, we're translating. We're taking the documentation from a report or an encounter, and then we're translating what was done and what's wrong with the patient into alphanumeric codes. If you've ever wanted in your youth to make out a secret code language, that's what this is. It's a lot of fun. So the guidelines, who makes the guidelines for us? Well, there's three main groups that make the guidelines. The first one is the AHA. You may not really hear them too much. You may see AHA, but we don't think about them per se on a daily basis. It's the American Hospital Association. Now, in your printout, it probably doesn't have the American Hospital Association added. I added that later. CMS, Centers of Medicare and Medicaid Services. You will hear about them a lot. They're prolific in what we do. Whatever Medicare does, everybody seems to follow in suit. That's just the way it is, because they are the largest provider in the United States. And then next we have the NCHS, which is the National Center for Health Statistics. As I've said before, what we do is for statistical purposes. That's what coding is designed to do, so that we know how many people got leukemia last year in comparison to 10 years ago, to comparison to 20 years ago. And we can even break that down into counties in the United States. So from states to counties. And that's extremely important when you apply that to the treatments that are being done. When I was younger, there was a young lady that I knew, she's a little bit older than me, and one of the first people I ever knew that had ever had leukemia. She had childhood leukemia. So if you think about this, this would have been 35 to 40 years ago. And at that time, children didn't do well with leukemia. But a new test, a new program had been set up with a special type of chemo for these patients. And I can't remember, I was thinking 13 or 14 children went through this study, and she's the only one that survived. But because she did survive, it changed and made an impact on the treatments that are set out that we're using today. And children with certain types of these types of leukemia recover because of the statistical knowledge that we've gained from coders. And that comes from the National Center of Health Statistics. They also work with the CDC a lot. Anyway, As a general rule, the AHA and the NCHS are not necessarily terms or organizations that you really think of as a daily basis. However, CMS is. They're always on the back of your mind. You'll be going out to their website and looking for information on cms.gov. So get used to that. In fact, right now during your studies, I would take time to bookmark cms.gov because you will use them as a resource often. Now, your guidelines are divided up into sections. Like I mentioned before, don't personally think of the chapters in the manual because I think of them more as their alphanumeric order. So I think of them by letter and the ranges. So I know that if it's a J code, it's going to have something to do with the respiratory system. And if I know if it's a C code, it's going to have something to do with cancer or neoplasms of some type. But some people think of them as chapters, and then each chapter. The same with the sections of your guidelines. I don't think of them as sections. I think of them as what the actual content is. That doesn't mean that your brain may work differently than mine, and you may think of it as sections 1, 2, 3, and 4. Now, for testing purposes, you will probably get a few questions about what's in section 1 or section 2. Okay, so but the good thing is you'll always have your manual there, and you can just open it up and say, okay, there's section 1. On a daily basis, I don't think of that. But you do need to know the different sections and what's in the sections. So section 1 is divided up to tell you about the structure, the conventions, and the general guidelines. That's where the guidelines themselves that we're going to follow, that tells you, like I mentioned before, what to code first and what to code second. When you code one code versus another code, or the guideline that tells you for diabetes, if they don't tell you what type of diabetes that your patient has, type 1 or type 2, what do you default to? And you default to type 2, and the guideline directs you to do that. So it's the rules, the regulations that you follow in applying the codes that you've looked at. Sections 2 and 3, this is going to be your diagnoses, your principal diagnoses for inpatient and additional diagnoses. Section 4 is all your outpatient. Also referenced though in 2 and 3. Okay, so you do need to be aware that coding for inpatient is different than coding for outpatient. That's important to know. And we'll highlight that a little bit as we're talking about some of the other slides here. But for the most part, just know that ICD-10 is the diagnostic manual that you'll be using. This is the manual that gives us medical necessity. Inpatient gets paid for medical necessity, and they're paid. So diagnoses are much more, not prevalent isn't the right word that I want to use. The education around diagnosis codes is higher because the procedure codes you're not getting paid for the procedure codes. Whereas with outpatient, it's what the provider does to and for the patient that establishes reimbursement, not the medical necessity or what's wrong with the patient. You still have to have medical necessity, but it isn't what the money's coming from, right? Your manual is divided up into 2 sections, the index and the tabular. Now there's more sections because we just talked about them, but what you're going to be dealing with besides the guidelines is going to be the index and the tabular. The index is just like an index in any other book that you've ever referenced, or think of even a dictionary. When you go and you find your word, it's set up like an index. The tabular, though, is where the definition falls. Okay, so think of a textbook that you're using. whether you're in high school or college, any type of a textbook. If you go to the index and you want to look up, George Washington, you go and you look up Washington, George, and then it tells you to go to page 95. Okay, then you go to page 95, and then it gives you information about George Washington. The same way that your manual works. In the index, if you need to look up diabetes, you're going to open it up to the D's. You're going to go to diabetes. It's going to say type 1, type 2, etc. But it's going to tell you where you need to go in the tabular, which would be E11.9 or E11. So then it's alphanumeric. So you'll go to the E section, and then you go to the 11 or the 11, and then you'll have a description of that particular disease or condition. Simple as that. An example that they're giving here for this slide is you have a person that is diagnosed with Hodgkin's disease. There's more than one type of Hodgkin's disease, but they're going to tell you to go and look at lymphoma Hodgkin's. So that would be like saying you're going to go look at George Washington, but there's more than one George Washington, right? So you need to know that it's what if there's any other descriptions, and this is George Washington, and then it might say first president. Okay, yeah, that's the first, that's the one you want. So the same thing, you're going to look under Hodgkin's disease. That's what your patient has, but they're going to say, hey, by the way, this is a lymphoma, so we want you to go look up lymphoma and then Hodgkin's, because there's more than one type of lymphoma. So you go in the index, the main term is going to be lymphoma, and then the subterm, it'll be indented, and it'll say Hodgkin's, and then it tells you the code for that is C81.9. Just so you know, there's more than one type of lymphoma, Hodgkin's lymphoma. And this is the C81.9 is a starting point. So you're now out of the index and you go to the tabular where we're going to get that description. In the tabular, you look at C81, which is Hodgkin's disease, right? That's a category code. We're looking at Hodgkin's disease, but there's more than one type of Hodgkin's disease that there's more than one description for. C81.9, whenever you see a code that ends in a 0.9, that is usually, not always, but usually an unspecified code. You may or may not have heard people talk about unspecified codes, and unspecified really means that there's no more information that you've been given to describe that particular condition. Some people or some payers don't particularly like unspecified because sometimes there are more descriptive codes. So let's go backtrack back to diabetes. If you have diabetes type 2 unspecified, then that's all you're given. You have type 2 diabetes. But quite honestly, there's several types of type 2 diabetes. There's several types of type 1 diabetes. And then they throw in the comorbidities, and maybe you have trouble with your kidneys, so you have or your eyes, retinopathy, or renal issues with your kidneys, and maybe you have skin issues with, so again, there's more descriptors in there. And so everything past that decimal is going to be descriptive, but unspecified usually means, 9 usually means unspecified. And that will help you when you go to test, because you can look at the question, and if the question states that the patient has type 2 diabetes with retinopathy, you're going to think, and you're going to look and say E11.9, that's unspecified because it's 0.9, right? So, but we have a higher specificity. With Hodgkin's lymphoma, we know we're going to C81. C81.9 is unspecified. We have no more information to give you other than this patient has Hodgkin's lymphoma. However, C81.90 is Hodgkin's lymphoma, unspecified, but unspecified site. So you can have Hodgkin's lymphoma in different parts of your body. And because we want to get to the highest specificity, we want to know where it is in the body. So C81.90 is Hodgkin's lymphoma, unspecified site. Now, if you take the time to, you can pause the video anytime you need to, but you can go look up C81.9. You can go look up C81 in the tabular and look at all the descriptions and possibilities. Don't worry, you don't have to have that memorized. But what you do need to know is that everything behind that decimal describes, is a descriptor to get to a higher specificity for this code. Why do we want to know that? For statistical purposes. And Hodgkin's lymphoma, great example to show unspecified site, but let's bring it back to, say, something that we're probably more familiar with, breast cancer. So with breast cancer, if it's left or right breast, that's going to be the last number. I was trying to say number and numeral at the same time. The last character in your code is the laterality, which we'll talk about in a little bit. But they can divide up what type of breast cancer in this code and where it's located in the breast, because it's divided up into quadrants. So again, why is that important? Because certain treatments are better for cancer in the breast and the different types of breast cancer, as well as the location. So it's pretty fascinating how those statistics can help us, and the codes give us that specificity. So again, what is the specificity, the level of specificity? Every time you get more specific, you're adding another character to your code description. After a while, you'll find yourself realizing that certain characters always represent something. So we know the first character is always going to represent what chapter you are in your manual. And I mentioned like J. So J44.9 is COPD. One of those codes that eventually you'll memorize. You don't have to memorize codes, and we don't necessarily urge you to memorize codes, but you just can't help it, especially when you get out there working, because the codes become repetitious for you. But we do memorize that J codes have to do with the respiratory system. So COPD is a respiratory disease, chronic obstructive pulmonary disease. But we have COPD unspecified. We also have COPD with asthma. We have COPD with bronchitis. We have COPD with an acute exacerbation. All of this is a higher specificity that describes what's happening, and it also gives, not just for statistical purposes, medical necessity. So if a person comes in and is seen for COPD, then you might expect the medical necessity to show that the person is going to have a pulmonary study done, right? We're just, checking the status. But if they have some type of exacerbation, we're going to have lab tests run. We're going to make sure they don't have an infection. We might have an x-ray to make sure that they haven't developed some type of pneumonia. They might also have a CT scan or an MRI done to confirm that we haven't tripped into emphysema, right? So those codes with saying that there's an exacerbation or an infection gives us medical necessity to do the tests that the provider needs to do, and they're getting paid for those tests that are being done in the workup, and how the doctor has to consider the plan of care. Right. You cannot report the fifth character if the sixth character is available. What do? You do an X. Now, we talked about this in a previous, I can't remember if it was the last chapter or the one before that, but don't fear the X. Some people freak out when they see an X because they don't know what the X means, but it's just a placeholder. And you'll only see the X really in that particular character space. You can't skip it because each one of those spaces is like a block and it has to have a character in there. So the example they're giving for this particular one is M48.48 XA, because the seventh character is for, uh, in this particular instance, is this the initial encounter? Is this a follow-up or subsequent encounter? Is this a sequela? We'll talk about all that later. But you can't have anything, you can't have just a blank. You can't have M48.48A just because there's no character for the sixth place. You have to have an X there. So again, if you don't have a sixth character, you have to put an X there so that you can have an A or whatever that seventh character is. Each spot is important. You really will only see an X in that fifth or sixth character. You won't see an X at the seventh character. You just can't skip a character, okay? You can have a shorter code, but you can't skip in the code. Now, the integral conditions, the diagnoses that you're given need to be to the highest specificity, as we just stated. But one of the things that new coders struggle with is knowing what to code. And I remember when I first started coding, I was so excited to code everything I saw. Everything that was wrong with that patient that was mentioned, whether it had anything to do with the encounter or not, because I had learned to draw out these codes and it was so much fun to look at these codes. It's that secret code language that we learned. So a diagnosis statement. You do need to know that if you're getting to the highest specificity for outpatient, you do not code signs and symptoms. Now we need to know, what are signs and symptoms? Signs and symptoms are the information that is going to allow the provider to diagnose the patient. The examples that they're giving here are fever, shortness of breath due to pneumonia. Right. So the patient comes in and they're describing, I haven't been feeling good. I've been tired. And they check their temperature and they said, have you had a fever? Yes, I did check my temperature. It was 99. And then, last night it was 101. That's why I came in. And I'm really struggling to get a breath in. I really, it seems to be getting worse. And so the patient is being seen for a fever and shortness of breath. That's what the patient's being seen for. However, when the provider does tests and listens to the lungs, auscultates the lungs, they diagnose the patient with pneumonia. Well, as a new coder, you want to code fever, SOB for shortness of breath, because yay, you know how to look up those codes, right? And then you would code pneumonia. But that's not how you do it, because the signs and symptoms of pneumonia are fever and shortness of breath. It's almost like a redundancy. It's common knowledge in the medical field that fever and shortness of breath are signs and symptoms of pneumonia. So we code to the highest specificity, and the highest specificity is pneumonia. We don't have to code fever and shortness of breath, right? Now, you're asking yourself, I can just see you're like, wait a minute, I'm not a clinician. I don't know what signs and symptoms are. How am I going to learn this? Well, one of the things that is helpful is to have the medical terminology and anatomy training, which you may be doing at the same time. If you don't have that, then you're going to study the disease process as you go along. And you're going to look at this verbiage: fever and shortness of breath due to pneumonia, due to. So that tells you, it negates fever and shortness of breath to be able to code pneumonia. And again, if you don't know, as you're learning, you will be able to ask and say, should I code this? Is this a sign and symptom of pneumonia? Some of these are just common knowledge. You're going to realize that you know more than you think you do. Okay, but it never hurts to ask. Even when you get out there as a coder, if you suspect that you should not code something as because it might be a sign and a symptom, then again, you can ask and they'll tell you. One more thing to keep in mind, inpatient is different. Signs and symptoms do get coded for them. So if you're taking courses for like the CIC or the CCS, the rules change a little bit. So this is for outpatient coding. This is the way the rules fall for outpatient coding. You don't code for signs and symptoms when you have a higher specificity. If you want more knowledge in this, you can get it by going out and looking at YouTube videos, looking at the CCO videos that we've done. We've talked about signs and symptoms a lot. It's a good point here to say the medical abbreviation for signs and symptom is an S/SX. Okay, I use that all the time because nobody wants to write out signs and symptoms. That's the approved abbreviation for signs and symptoms. And you will, your knowledge as you go through the course, as we get into the individual body systems, your knowledge of signs and symptoms will increase. So don't fear that. Now, what is not an integral condition? So if it's not a part of the disease process, we're going to report it separately. Great example they've given us here, pneumonia and dehydration. Pneumonia, J18.9. Again, you might want to jot that down. It's a pretty common one, so not one that you have to memorize. I wouldn't make a note of it in your manual. What I would suggest you do, and this is a good time to tell you this, let me just reach over here. While you're doing your studies, I would just get a notebook, or maybe even the back to school notebooks, and you can't really see mine per se, but I've got stuff written in all of this. When you're doing a study for a course, it's a good idea to have a notebook that you can jot down things that you want to go back and reference again, or you want to get more information on, you know. Plus, just the art of writing something down with your hand helps you retain that knowledge. So that's a little suggestion I would tell you to do while you're studying. Don't necessarily write these type of codes in your manual because they're already in there. Right. J18.9, pneumonia. Why do we know about that 0.9? That means it's unspecified. There's more than one type of pneumonia. So go look up J18 and you'll see a whole list of different types of pneumonia. But even though it doesn't say unspecified here, J18.9 is just plain old pneumonia, no other information. And then dehydration is E86.0. How you know whether it's a sign or symptom is to ask yourself this next question. Everybody that has pneumonia, do they get dehydration? No, they don't. Is it common? Yes, it is common, actually, especially in older people, because when you can't breathe and get an air in, you definitely don't feel like eating or drinking anything. So it is common to see diagnoses of pneumonia and dehydration together, especially in elderly or the young, the very little. So ask yourself, if I have pneumonia, am I going to have dehydration? No, not necessarily. If I have pneumonia, am I going to have a fever? Yes, because it's part of the disease process. Am I going to have shortness of breath when I have pneumonia? Yes, because your lungs are filling up with fluid, so you can't get air in. So that's what you ask yourself. And again, when I said previously, some of this stuff is common knowledge, right? When you have a cold, what are the signs and symptoms? You may not necessarily have a fever with a cold, but you might, depending on if your cold is a virus or bacteria, right? So a sign and symptom of a cold might be a fever, definitely would be nasal congestion, right? Uh, you could have a cold and also it burn and you could have shortness of breath with a cold as well. So again, think to yourself, when I have a cold, what's normally are the signs and symptoms associated with it? What's not? That will help you as you move along. I'm just looking to see. any questions that come up. Okay. Etiologies and manifestation. Now, I don't call I don't call them this in my brain, etiology and manifestation. You will see those terms. What you need to know about etiology is how did they get the disease? Okay, diabetic retinopathy. The etiology for the retinopathy is diabetes. That's what caused the retinopathy because it's diabetic retinopathy. That's the etiology. That's what caused it. But the manifestation is what happens as a result of the etiology. Okay. So with etiology, I don't think to myself in medical terms, etiology, not necessarily. Think what's the cause, and then manifestation, what's the result. So if you put it back in layman's terms, whenever you see etiology and manifestation, it'll click for you and it won't get confusing. But these are definitely terms that you'll see again and again, especially in testing purposes. But when you're looking at documentation, sometimes they'll say that, the etiology is, but not often. And they may say it manifests itself. It doesn't. You just need to know that diabetic retinopathy, the etiology is diabetes and the manifestation is retinopathy because you understand the disease process. Okay. There is a combination code for diabetic retinopathy. Anything that I want to teach you in ICD-10 can pretty much be taught through diabetes. So you're going to hear it referenced a lot. And it's important for you to go ahead and look at your manual in the tabular at E10 and E11 codes because there's laterality in there is combination codes, and also you can learn the signs and symptoms and stuff. All that can be taught right there in that section. Plus, diabetes is so common in our society that you're going to see it again and again. But because it's easy to teach guidelines and even the disease process through diabetes, you see it on a lot of test questions. So it's a good idea to study up on diabetes. Diabetic retinopathy, that's the etiology and the manifestation. So what code would we use? We would use E10.319. Now, E10 or E10 is type 1 diabetes. E11 is type 2 diabetes. What would be a good way to remember that? Well, E10 only has one in it, so it's type 1, and E11 has two ones, so it's type 2. Maybe that would be a good way? I don't know. You can come up with a way. Let us know in the chat. So what this tells me is we're in the endocrine system. 10 is type 1 diabetes. Everything that is E10 will be a type 1 diabetes, no matter what. Everything that starts with E11 or E11 will be a type 2 diabetes. Then we have the decimal, and now we're going to get into some real descriptors here. So 3 happens to be the eyes. Everything that has to do with the eyes in E10 is going to start with a 3, just so you know. Then the 1 is going to be more of a descriptor as to what is wrong with the eyes. Well, they have retinopathy because there's several things that could go wrong with the eyes. And then the 9, I can't remember what the 9 is, but it isn't unspecified in this situation because usually if it's a 0.9, that's when you'll see unspecified, okay? All right. Um, you can see laterality, which I'm going to show you here in just a minute. Now let's look at another code. Staphylococcal aureus, which there's more than one type of staph, but we would just abbreviate this. They've got staph cellulitis of the face. Cellulitis is just an inflammation of the skin, and it's of the face. So you have to use 2 codes to describe this, not the 1 code that's a combination code that gives us the etiology and the manifestation for the diabetic code, because it's so common. That's why it's got a combination code. In this situation, we have the etiology. The Etiology is that this patient has a staph infection. So what's the result? What's the manifestation? Cellulitis of the face. We have to have two codes. The cellulitis code of the face is L03.211, and your L codes will have to do with the skin, the integumentary system. 03 is going to give you that it's cellulitis because there's all kinds of conditions of the skin. And then the 0.211 is the descriptor, which will ultimately say that it's of the face. Then we have to code also why they have the cellulitis. Cellulitis is usually caused by some type of bacteria. And the bacteria in this situation just happens to be staph. So B95.61 is the staph infection. There's more than one type of staph infection. That's why you have a longer code. There's staph B or strep B. I can't remember. There's lots of staphs and there's lots of streps. But this is Staphylococcal aureus. And so the code is B95.61. It takes two codes to get the etiology and the manifestation for this particular scenario or this diagnosis, whereas with the diabetic retinopathy, it just so happens that it's conveniently all summed up in one code. You don't have to worry about if there's a combo code or not because your manual is going to tell you. What it's going to say is when you look at code L03.211, there's going to be a notation in your manual that says code also or use additional the type of bacteria if you know it. And it'll even give you suggestions that'll say like B95 or something like that. Go look over there. And then when you go look at B95 and you see the staphs, it's going to say, hey, you code first what caused it. Okay, so that's part of the guidelines. It tells you, it cross-references all the time in your codes. So don't get excited. Don't think, how am I going to learn all this stuff? Don't worry. The manual tells you what to do. It's fantastic. And then before you know it, you're going to start remembering that. You'll start saying, oh yeah, almost all diabetic codes have combo codes. And whenever you have any type of bacterial or infection, like a cellulitis or something, it's almost always going to tell me, hey, if I know what caused it, go put that code in there. Why do they want to know that? Well, we want to know of all the people that had cellulitis in Anywhere USA, in Happy County, how many people had cellulitis due to staph? How many staph infections did we have that year? Now we'll know. Acute and chronic is also extremely important when coding. The main thing you need to know about acute and chronic is that acute always gets code first. Okay, if somebody has an acute injury or an acute exacerbation, it's going to trump the chronic code because it's acute. It's a sudden onset. That's what acute is. Whereas chronic, we already know about. It's going on and on and on. Pain is a great example of this. Maybe a person has acute and chronic pain. There sometimes are codes for acute and chronic pain. But for this particular scenario, we have a person that has pain. So we go look it up in the index. And if they have acute pain, it's R52. If they have chronic pain, it's G89.29. That's completely different sections. That's an R and that's a G. Isn't that interesting? Okay, so if a person has acute pain, it's an R code, but if it's an acute pain due to something, look, it jumps over to G codes. Acute pain due to trauma, G89.11. Neoplasm related, G89.3. Post-procedural, G89.18. Again, now look at the chronic pains. Chronic pain associated with significant psychological, no, does that say psychological? It's print is really dysfunction. G8 9.4, chronic pain due to trauma. That's completely different. It's G8 9.21, whereas if it's acute pain due to trauma, it's G8 9.11, because G8 9 is pain due to trauma, okay, whether acute or chronic, but 0.1 tells you that it's acute, and the 0.2 tells you that it is chronic. And then I don't know what the one after that is. I have to go look it up. Again, neoplasm related, post-operative, post-procedural, specified, not elsewhere classified. We'll talk about that later. So again, if I were going to write a test question and I were going to say that Mr. I'm trying to think of a good name there. Mr. Jones was walking down the sidewalk, twisted his ankle, and now he has pain. It would be acute pain due to trauma, G8 9.11. If our patient was diagnosed after he went to the ER with a fractured ankle, we wouldn't code the pain, would we? Because we know that a fractured ankle would have pain. Okay, so that's going back a slide or two. Remember when we talked about that? We get to the higher specificity. Then, but if after the patient's ankle had healed and was no longer getting treatment on that fracture, and he continued to have chronic pain, the doctor diagnoses him with chronic ankle pain, then it would be chronic pain due to trauma, due to the trauma that he had to the ankle, G8 9.21. There you go. Okay. Be very careful with acute and chronic when you're getting test questions. Make sure you understand the difference. So with combination codes, you're going to have two diagnoses. You're going to have the diagnosis and a manifestation, or you could have the diagnosis with associated complications, both complications and manifestations. They are different. They sound like they might be the same. Manifestation is the result of, but associated complications is still kind of like a manifestation, but it's a higher specificity of a manifestation, I guess, would be the good way to say that. An example, K80.00 is acute cholecystitis, which is an inflammation of the gallbladder with cholelithiasis, which, if you didn't know, is like a buildup of fluid and stuff. And that is a combination code. We have K80.00. So we have an acute gallbladder attack, ultimately is what we're thinking. Their gallbladder is inflamed, but it also has something else going on with the gallbladder, which is an associated complication. Randa, let's see, can you speak a little bit about additional diagnoses and when to add them? Yes, good. This would, when you need to get to a higher specificity and there is not a combo code to be able to use, okay? We will talk about that some more, and we'll talk about it in the next chapter as well, the next lecture we do. But an example of an additional diagnosis code would be a patient that had more than one diagnosis, right? Because you're not going to code signs and symptoms like pneumonia and dehydration. That is two diagnosis codes. Now, you may say, which one do we code first, right? A lot of people get confused as to that. Ultimately, that ends up being about severity. When you're doing outpatient coding, the diagnosis code, unless you're told how to code it, meaning code in addition or code first, it doesn't really matter per se, because that's not how you're getting paid. It's a statistical purposes. There is rules as to, and guidelines on, what to code first and second when a code, if a person has a strep throat, you're going to code the strep throat, and then you're going to code the strep and what type of strep, because they have strep throat, and then we get to a higher specificity as to saying what type of strep that they have, okay? So we will talk about that, and that's something you get better at as you go along with experience as a coding and through the course. It'll start clicking and falling into place. This example is a person can have cholecystitis without cholelithiasis. I can't say that word very good. And a person could have cholelithiasis, man, that's hard to say, and not have cholecystitis. So there just happens to be a combination code because it's common to have them together. That's K80.00. But you could have one or the other separate. The fact that there's a combo code, you don't have to worry about which goes first. But let's say, for example, there was not a combo code, that these were two separate diagnoses without a combo code. Which one would you code first? What do you think? Quite honestly, it doesn't matter, because both are equally problematic, ultimately, is what it comes down to. But let's say that the person this is going to be an obscure example. Let's say the person has acute cholecystitis and a brain tumor. So which would you code first? If the patient's being seen for both of those that day, which is more severe? The brain tumor, right? If a person has acute cholecystitis and they also were diagnosed last week with pneumonia, not acute pneumonia attack, but they have pneumonia, which is more problematic? Acute cholecystitis, because they're probably going to need the gallbladder taken out, right? You always code first what they're being seen for that day and being treated for. If they're being treated for more than one thing and there's not a combo code because they're commonly coded together, then you have to go by which is more severe. How do you know? Because I know you're saying, wait a minute, I'm not a doctor, I'm not a nurse. How do I know which is more severe? Well, for the most part, it's common sense. Okay. If it's not, then it doesn't matter. If acute cholecystitis and acute cholelithiasis, I got to quit saying that word, find a way not to say it, is equally problematic. Okay. So if there's not a combo code that lumps it all together, then it doesn't matter. If a patient's being seen today for two combo codes, like the person has diabetes with retinopathy and they also have diabetes with a skin condition, maybe they have a break on the skin in the toe, which is more problematic, both are equally problematic, and it's not going to matter which one you code first. Okay. Residual and cause. Now, sometimes people get confused with etiology and manifestation, but it's not the same. Residual and cause. So if something is sequela or a residual, that's a late effect. The example they give is, the cause is a late effect, whereas the residual is something like malunion of a fracture. Okay, let's describe what a malunion of a fracture is. Malunion of a fracture is a person that has a fracture like this. They put it together like this, all right? And it's still separated, so it's going to heal in between. But if it's not healing, if it's not uniting, it's a malunion, right? And that's a residual effect of the fracture. What is the cause? The late effect of the fracture. It's a late effect of the malunion. Report residuals as first listed diagnoses. So what are you going to code first? The malunion of the fracture. So if you have a fractured femur, malunion of a fractured femur, there's a code for that. Then you can code by the late effect, right? So what's the cause of that? Maybe they have osteoporosis, and so it's not healing properly. Followed by the late effect code, but sometimes you get a combination code so that you could still report one code, or you have to report two codes. It's just like the previous slide, but it's a residual and a cause this time. The residual is the malunion of a fracture, and then the cause is the late effect of the fracture. Laterality, this is where we're summing everything up. Laterality just means left or right. So our body, we have a midline, medial, and when something is referred to as distal, medial is towards the center, distal is always farther away. So if I injure my shoulder and I injure my arm and it's a medial injury, it's up here. If it's a distal injury, it's down here, right? And they even divide up medial and distal to bone. So if I fracture my femur, is it a medial fracture or is it a distal fracture? Meaning if you divide the femur, this would be in the middle. Is it farther away from my body or is it closer? Okay. With laterality, that's different. That's always left or right. Always left or right. There are so many things that can be left or right. If it can be left or right, it will have a laterality code to it. There may be a few exceptions, but this is really what ICD-10, one of the main things that it did to make coding easier is things that didn't have laterality in ICD-9, they gave it in ICD-10. And when everybody was freaking out about there being so many more codes for ICD-10, well, majority of those codes is just giving laterality, right? A left or right option. But they didn't give just a left or right option. They gave, for every laterality, there's 3 to 4 codes that could be added because you have a left, a right, both, or it doesn't tell us either one. Okay. So, very extensive laterality in ICD-10. What do you do when you're not told? For the most part, you'll always be told in your documentation, but there will be instances when you're not. And so you'll have codes that are unspecified. And guess what? They're probably ended in 9. 9's that unspecified. Not always. The example they're giving here is soft tissue disorder related to overuse of pressure of a hand. That's kind of a broad type of a code, not very specific. But here's our laterality. M70.841 for the right hand, 0.842 for the left hand, and 0.849 for unspecified hand. They didn't tell us if it was the right or the left. Now, when I told you that payers don't like unspecified, this is where they don't like unspecified. Because if you're treating somebody for an injury to their hand, you better document which hand it is. Because if you don't, that is really poor documentation they consider. So again, for an injury like this, then or a disorder, you better not use the 0.849, or at least don't use it after you start a treatment, for sure, right? Now there will be situations where this code is applicable and you need to use it. But when people talk about unspecified, this is a classic example of, if a person has an injury to a hand, you better let us know which hand it is before you treat it or after you started treating it. You have laterality in your eyes, your nares. You have laterality in your face, the left and right side of the face. You have laterality in your ears, your limbs, your extremities. You have laterality in your pelvis. You have laterality in the breast. You have laterality in your lungs. You have laterality in your kidneys. You have laterality in your ovaries. I mean, there is just so much that you have laterality in, okay, that you just need to be aware of it. And it gives you a higher specificity. So when I talked about breast cancer before, if you have breast cancer, there's laterality. They're going to want to know if it's the right or the left breast. They're also going to want to know then what quadrant of the breast that it's in. So, in the abdomen, you have laterality in the abdomen when you're doing procedures, right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Okay, and so you need to know that because there's anatomy. If you have patient has pain in their right lower quadrant, then that means it's not going to be your appendix or your gallbladder, because that's in your left and right upper quadrants, things like that. So having laterality and to be able to get to a higher specificity in location is extremely important, because we know the anatomy and what organs, for example, are in the abdomen. If a person for laterality has a problem with their eyes, let's say, I know things are switched in the camera. This is my right eye. If my right eye is blown, the pupil's blown, it's very, very large. And the left one's not. What does that tell? And I'm having a severe headache. What does that tell the provider? That tells the provider that there's something wrong with the left side of my brain, right? Because that's the way the disease process works in the brain. It switches. So laterality is extremely important. This is the area that they're going to look at. This is the parts of the brain that are going to have deficits. If I have a bleed or something's going on, it may start out with the eye, but then pretty soon I might lose function of my right hand or have numbness in my hand, et cetera, et cetera. And so laterality is very important to the disease process, and it's very important to distinguish a higher specificity when we need medical necessity. Okay, and this particular example doesn't show that you have right, left, and unspecified, as well as both, bilateral. It'll say both. So if you have a burns to the hand, it'll say burn of hand, right, left, bilateral, both hands, or unspecified. So again, there's 4 codes instead of 3. All right, very good. Any more questions? So again, because I think that was our last one. That is it. I'm not seeing any questions. If you have any questions, what you need to do is go to the CCO Club. If you're one of our students, then you have access to the CCO Club, and you can go to the course student support hub and ask your questions there. Not only will I be in there to answer your questions, but we have other students that may have already experienced one of the things that you're struggling with, or other subject matter experts. We've got lots of them looking in and helping out. Your coach will be in there to help you along and encourage you, but not just with questions. If you see a great example of something that maybe shows laterality, or a combo code, or something that you found very, very interesting, go ahead and pop it in over there at the CCO Club, because it allows a communication. If you found it interesting, it's probably going to be helpful to somebody else. Maybe you come across a great scenario or an article that talks about coding for laterality or etiology and manifestation. Cool, pop it in. Let us all share with each other and increase our knowledge base. You're going to find a lot of things, let me tell you, about the disease process as we go along through this course. Take time to jump out to our YouTube channel and kind of peruse some of the little videos that Boyd has put in there, because that'll help you with not only the coding, but some of that stuff really talks in depth about the disease process. If you do, don't forget to like and subscribe our videos, as well as on Facebook. Don't forget to like and share those as well if you think they're helpful. All right, guys. See you next time. Another great chapter coming up next. Bye-bye.